I'm Margaret Tempero, immediate past president of the APA, and I'm delighted to introduce this first lecture of the last day of our virtual meeting, our first virtual meeting. I'm going to be introducing the lecturer for the Paul Webster lecture, very important lecture for the APA. Dr. Eileen O'Reilly probably needs no real introduction to most of you. Dr. O'Reilly is the section head for hepatopancreatobiliary and neuroendocrine cancers and the GI oncology service at Memorial Sloan Kettering. She's an attending physician and professor at Weill Cornell. She holds the Winthrop Rockefeller Endowed Chair in Medical Oncology. She's also co-chair of the NCI Alliance Cooperative Group Gastrointestinal Cancers Committee, and she serves on many advisory boards and holds many other important positions as well. She's going to be speaking to us about the genomics era in pancreas cancer, truth or fiction. Eileen, take it away.
Good morning. Eileen O'Reilly here from Memorial Sloan Kettering Cancer Center. Thank you very much for the invitation to give this lecture. It's entitled Genomic-Directed Therapy in Pancreas Adenocarcinoma, Truth or Fiction. So these are my disclosures, and please note that there'll be a number of off-label investigational uses that will be mentioned. This is the agenda, going to focus on the genetics of this disease, how this intersects with therapy, and the latter part of the talk will review DNA damage repair strategies in pancreas cancer. So this slide has been borrowed and adapted, so thank you. And it illustrates the treatment landscape in pancreas cancer for 2020. And you'll see the blue boxes are standard cytotoxic therapies, which remain an option for all patients with this disease. And the red boxes represent targeted approaches. Just to note that erlotinib was approved in the setting of non-genomic selection, although may have a role in the KRAS wild-type subset of patients with pancreas cancer. Olaparib FDA approved in late 2019 for germline BRCA1, BRCA2 altered pancreas cancer, and then pembrolizumab and NTRK fusion inhibitors, larotrectinib and entrectinib, have disease agnostic approvals. So these are the current guidelines for pancreas cancer, starting with the NCCN in 2019 and the American Society of Clinical Oncology Metastatic Pancreas Cancer update in 2020, that germline testing is recommended for all patients with this disease using a multi-gene panel, which includes BRCA1, BRCA2, the Lynch genes, PALB2, ATM, CHEK2, and a number of other critical genes that are associated with both predisposition to pancreas cancer and potential targeted approaches. And that tumor and somatic profiling is recommended for all patients who are candidates for additional treatment, with the gold standard and reference being tissue, but with the option of ctDNA being a consideration. Having said that, we still have a lot to learn about the use of ctDNA with regard to its sensitivity in pancreas cancer, and to note that pancreas cancer may shed less ctDNA compared to other malignancies, so it's unclear yet whether it represents an optimal surrogate for tumor. This is one example of many genomic sequencing protocols that have been conducted in pancreas cancer. This is from MSK and looks at an initial review of 300 plus patients with this disease, and all of these cohorts are characterized by frequency of oncogenic mutations, including KRAS, P53, CDKN2, and ARID1A. And they're also characterized by a lower frequency of other alterations, some of which are targetable, in particular in the DNA repair subgroup, and that we're seeing now that there's a reproducible subset of KRAS wild-type pancreas cancer, and we'll speak to this a little further momentarily. But firstly, looking at KRAS targeting and where we are. So there are allele-specific inhibitors that are in the clinic for 12C. It's about 1 to 2% of individuals with pancreas cancer. autophagy approaches have gained some traction in the last couple of years, combined with both MEK inhibition and checkpoint inhibition. And we'll see how these pan out. We do have one early experience looking at hydroxychloroquine combined with gemcitabine and nab-paclitaxel, suggesting that response rates were higher, but this did not translate into an improvement in overall survival. And then very excitingly is the intersection of KRAS targeting and immune therapy approaches. There are a number of vaccine strategies targeting 12D and 12V in the clinic, and mRNA-based vaccines also in the clinic, which are being evaluated in particular in the adjuvant setting in pancreas cancer. So looking at the data for 12C inhibition in this disease, recently in the New England Journal of Medicine, Dr. Hung and colleagues reported the experience of AMG 510 or sotorasib in 12C mutated solid tumors. There was a cohort of 12 patients with pancreas cancer in the supplementary files, and this is a table or at least a waterfall plot borrowed from that source, which describes the outcome of those 12 patients. There was one who had a confirmed partial response. There were others who had stable disease. Key point to note is there is proof of principle here, but these responses were not so durable. But nonetheless, I think it's clearly a strategy to build upon. And also in recent data published in Cancer Discovery in 2020 is looking at preclinically targeting SOS1 and using a MAP kinase combination to reduce the rebound redundant pathways that may be inhibited by targeting a single strategy or single signaling pathway in pancreas cancer. And this combination will start in clinic shortly and illustrates that there's opportunity beyond 12C, in particular D and V, which are the most important and frequent KRAS mutations in pancreas cancer. And this is one of several approaches that is positioned now to be proximately in the clinic. And I think there's real excitement in the near future as we see these develop. So antisense targeting has also been looked at in terms of KRAS. So SIG12D is a small interfering RNA against 12D in particular, but also 12V. It's an antisense oligonucleotide that has been developed by a biotech company in Israel. And preclinically, you can see that there's proof of principle in terms of reduction of the specific mRNA against 12D. And if you look at the mouse model of pancreas, PANC1 model, the panels on the right looking at the loader, which is the delivery device which contains the drug. And the reason for the delivery device is to prevent and reduce the enzymatic degradation and to allow slow release of the drug over approximately 3-month period of time. You'll see that this induced tumor regressions in a mouse model. And this has gone on to be tested in a phase 1 clinical trial, which showed that this was safe. This drug is delivered endoscopically, like little gold fiducials that are delivered directly into the pancreas. And then the drug slowly released over weeks to 3 months. And this is followed on in terms of initially a randomized phase 2, although there was some challenges with that, collapsed into a single arm phase 2 combined with the 2 standard regimens in locally advanced inoperable pancreas cancer, with a plan to go on to develop this in a randomized setting in locally advanced unresectable pancreas cancer. We're hoping that that large trial global study will start in 2021. So a couple of comments on the epidemiology of pancreas cancer and why this is important from the genetic perspective. So this disease is getting more common, although the incidence is stable in older people, but where there's a change is in younger people. There appears to be an increased incidence of pancreas cancer, although proportionately this remains a small percentage of the overall incidence of pancreas cancer. The significance here is that younger people appear to have more KRAS wild-type tumors. So this is a 3-cohort analysis looking at early onset pancreas cancer, those diagnosed younger than 50, compared to those over 70. And the major difference was not so much in the oncogenes that are mutated, but in the frequency of KRAS mutations. You'll see 83% versus 96%. And we went on to look at this further, and these data are now in review, and confirmed that KRAS wild type subset is prevalent in younger people, about 16%. And again, the implications of this are that there are actionable alterations beyond KRAS. So these can be perhaps classified as 3 subgroups: the fusions, single gene alterations, which are targetable. These individually are about maybe 0.5%, maybe 1% at most in terms of NRG1, NTRK, ROS, ALK, FGF, and RET. MAP kinase alterations, BRAF, and V600E occasionally, and fusions, HER2, pathway amplifications, mutations, and also there may be more patients with mismatch repair deficiency in the KRAS wild type subgroup. So looking at this from the targeting perspective, this is an example of targeting the uregulin pathway with a drug called MCLA-128 or zenocutuzumab, which inhibits heterodimer formation in NRG1-driven pancreas and other malignancies. And you can see here that this translated into an objective response, reduction in CA19-9, along with significant clinical improvement. So very exciting, and this is now being developed as a drug with potential registration intent in pancreas and other solid tumors. Similarly, NTRK fusions occur in pancreas cancer, rare. This is an example of the H&E slide on the top left. On the bottom left is the immunohistochemistry for NTRK1 fusion presence alteration, the Archer profile, and then the PET scan pre and post treatment. And again, objective response and clinical benefit was obtained for about 6 months with a single agent targeted approach. So for these patients, important and providing opportunity away from cytotoxic therapy. So what about mismatch repair deficiency in pancreas cancer? Initial reports suggested that this was common. We now know this is probably 1 to 2% of pancreas cancer at most, and tumor responses are seen with immunotherapy. Mismatch repair deficiency is characterized by loss of mismatch repair protein expression as adjudicated by IHC directly on the tumor, associated with a high mutational load, which is more neoantigens for the immune system to respond to, and by bioinformatics analysis, an elevated an elevated MSI sensor score. So looking at this graphically, the average patient with pancreas cancer has a low number of mutations per megabase, about 1 to 3. Patients with mismatch repair deficiency may have more than 50, but this is not as high as we see in endometrial and colorectal cancer, and this may have significance. And then to mention that there's a few percentage of people who have mutational loads greater than 10, the importance there being the approval of pembrolizumab in a disease-agnostic setting for solid tumors where the tumor mutation load is greater than 10. None of the patients in that cohort that led to the approval on that basis in fact had pancreas cancer, so we really don't know what the significance of this is. So more to come on that topic. So here's the cohort that were presented from the Keynote 158 trial by Dr. Aurelian and Diaz and colleagues at ESMO and simultaneously reported in JCO for solid tumors beyond colorectal cancer. And in the pancreas cohort of 22 patients, there was some benefit to immune therapy, but nonetheless, progression-free survival and overall survival seemed quite short compared to other solid tumors such as endometrial and ovary and biliary cancers. So we looked at this further in our experience with mismatch repair deficiency and pancreas cancer. So firstly, those who received immune therapy compared to those who did not. And this is a crude analysis here in small numbers, but nonetheless, there appeared to be a striking difference. So no surprise in that. But secondly, those who did receive immune therapy appeared to fare much better than the cohort that was published. And that's been our experience. And we have a number of patients who continue to drive benefit. I think the longest now that I'm looking after is in the 5th year of various immune therapy approaches and continuing to benefit with an oligometastatic phenotype of pancreas cancer. So I think very important to identify these patients and treat them accordingly. So moving to the topic of DDR-directed strategies in pancreas cancer, and just a reminder again that about 10% of patients with pancreas cancer will have a germline pathogenic mutation, which is potentially targetable, also implications in terms of family and for screening. And most of these alterations are in DNA damage repair genes, such as BRCA1, BRCA2, but also ATM, potentially CHEK2, and a series of much lower frequency alterations. So Dr. Prishvayan and colleagues have greatly contributed to the work in this field from the Know Your Tumor program from the Pancreas Cancer Action Network, and have shown us that if you have a DDR gene mutation, it's really important that you receive platinum therapy. And this is important both in the advanced disease setting and in the early stage disease setting. And those who received platinum compared to not, for those who had a DDR mutation, had a substantial difference in outcome. And you'll see here, these are not trivial, of the order of magnitude of about a year and highly significant. And our group also looked at this in a more detailed, smaller cohort of 262 patients who had advanced disease, of which 50 had DDR gene alterations. And again, underscoring the point that platinum early matters, and that having a homologous repair mutation compared to not may in of itself have some prognostic impact in pancreas cancer. So moving to the principal trial that's led to the approval of olaparib in pancreas cancer. This is the POLO study that was presented at ASCO in 2019 with a simultaneous publication in the New England Journal of Medicine in a trial that evaluated patients with germline altered BRCA1 and BRCA2 pancreas cancer who had received at least 4 months of platinum-based therapy and who had either stable disease or response, and went on to get randomized to either olaparib or placebo. And to note here that there wasn't a control chemotherapy arm. And again, to note this is a highly selected patient population, selected based on genetics and selected based on response. The outcomes nonetheless were significant. Primary endpoint was progression-free survival, and there was a doubling of progression-free survival for those who had received pancreas cancer compared to those that received olaparib, compared to those that received placebo. You'll see the hazard ratio of 0.53. And doubling of response rate for olaparib compared to placebo. But there wasn't a difference in overall survival. The data at the time that this was presented was not mature for overall survival, so we'll see how the longer term signal looks, and we're hopefully looking forward to seeing those data in 2021. So this establishes proof of principle for use of a PARP inhibitor in pancreas cancer compared to placebo. Nonetheless, resistance is a key issue in pancreas cancer, occurring for some patients de novo, but often acquired proximately in the treatment course. So strategies here to delay resistance include combining PARP inhibitors to chemotherapy. This is a randomized phase 2 trial that we conducted with collaborators in North America, Canada, and Israel, looking at adding a PARP inhibitor to chemotherapy in germline BRCA1 and BRCA2 and PALB2 selected pancreas cancer. Principal endpoint of this was response. We saw that both the triplet of chemotherapy plus PARP inhibitor and the the doublet of chemotherapy, platinum-based alone, were both very active. This is the waterfall plot illustrating that, but we did not see a difference that was statistically significant for the triplet over the doublet, and the combination was more toxic with significantly more myelosuppression. However, the survival signal was encouraging, and I'll just make note here that progression-free survival was 10 months in this patient population, and overall survival was 15 to 16 months. And in our subset, which was about 60% of the patients at MSK, survival was about 2 years for this patient population. But overall, about a third of patients lived 2 years, and about 20% of patients lived 3 years. So again, illustrating the importance of identifying these patients and finding them and making sure they receive a platinum therapy, ideally early. I think the graphical illustration is very compelling. This is an example of a patient who's allowed me to share her story. She has advanced pancreas cancer, enrolled on this study, had a germline BRCA alteration, received platinum combined with the PARP inhibitor and maintained on a PARP inhibitor. And you look at the timeline here from 2016 with ongoing to 2020 with excellent quality of life on a single agent targeted medication now for well over 3 years. However, it is important to acknowledge that we need to use these drugs judiciously, and for the most part, the data suggests that PARP inhibitors do not work in platinum-resistant disease. And you'll see here, this is a small experience, but the waterfall plot is in the wrong direction. So other colleagues, Kim Rees-Binder and Dr. Schroff, have also demonstrated the role of PARP inhibitors in previously treated pancreas cancer in platinum-sensitive disease and in the maintenance setting. And we look forward to hearing more on their data. This is a trial that's going to open shortly at MSK, which evaluates using DNA damage repair as a selection tool, either genomically in terms of core genes or in terms of non-core genes beyond BRCA1, BRCA2, and PALB2, and also the phenotype of patients who have an excellent response to platinum-based therapy in this disease, and to look at the combination of olaparib plus immunotherapy, the concept being that genomic instability appears to be higher in patients who have DNA damage repair gene alterations, so potentially more targets for the immune system, and this may prove of added value. So where do we stand in PARP inhibitors in their use in pancreas cancer in 2020? So established in the subset of germline BRCA1 and BRCA2, pending data or more data in PALB2 and somatic BRCA1 and BRCA2, and for sure in other homologous repair gene alterations. Established as a maintenance approach in platinum-sensitive disease. 2 major cooperative group studies will open in 2020-2021, evaluating olaparib as an adjuvant therapy following platinum-based treatment for germline altered BRCA1, BRCA2, and PALB2 pancreas cancer and somatic mutations in those genes too. And also Dr. Chung and colleagues will look at maintenance olaparib with or without pembrolizumab, so looking to see if pembrolizumab is indeed adding to the role of olaparib as established in the POLO study. And there are multiple approaches trying to address the issue of resistance with combinations with various targeted approaches, with chemotherapy, with immune therapy, and with VEGF targeting in pancreas cancer. So just to comment once more on the importance of finding these mutations, this again comes from the Know Your Tumor program from Michael Pishvayan and colleagues, recently published in the Lancet Oncology, looking at a cohort of patients who had a genomic alteration and received a targeted therapy compares to those who had a genomic alteration and did not receive the targeted therapy compared to those who did not have a genomic alteration. So I know that's complex, but the bottom line here is it matters. If you have a target and you receive a drug, you appear to do better. And that, again, that benefit was substantial for those patients. Need to acknowledge the caveats of this. This is a small patient subgroup, highly selected, and we just have to keep that in the context of the bigger picture. But again, illustrates the importance of looking for these alterations and providing an appropriate matched therapy where possible for these patients. So I'm going to sum up. In 2020, I think it's fair to say we do have an actionable genome in pancreas cancer, established now platinum and PARP inhibitors in the approximately 20% of patients who have a DNA damage repair gene alteration. And the specifics are described here. A subgroup of mismatch repair deficiency, about 1, maybe 1.5% of patients with pancreas cancer. We don't know yet the significance of the TMB greater than 10. I think data will follow quickly as we understand this. KRAS targeting is becoming a reality, and some hints in certain subsets, the 12C, that there's an oncologic signal, but we need to build on this, and we certainly need to look beyond 12C, 12D, 12V, and 12R being the other major KRAS mutations in pancreas cancer. And just remembering, again, the KRAS wild-type subgroup, 6 to 8% overall, more in younger people with actionable fusions for which there are drugs in development or approved in disease-agnostic settings, BRAF alterations, etc. And this is the totality right now for the major actionable alterations in pancreas cancer. So I just want to acknowledge a huge thanks to all my colleagues at MSK who contribute to all the work that we do, and to thank you all to the APA for the opportunity to present this lecture today.
Thank you very much, Dr. O'Reilly. That was fantastic. We have time for a couple of questions, and I think there is one in the chat here. What is this? This is from Sukhwinder Kaur. What is the status of ARID1A in pancreatic cancer, and is it targetable?
Thanks, Margaret. So I think this is a good question because ARID1A is one of the common genes, maybe in about 8 to 9% of pancreas cancer after the big four. And it has been hypothesized to be a gene that may promote genomic instability and be potentially targetable. I think we have found that the signal here is yet to be validated with regard to its actionability from the DDR or HRD perspective, and it's still being looked at. We have a couple of examples of this gene set up as a model in organoids and have tried to interrogate it, and we have on one hand in the modeling seen that it may have an HRD signature, but that hasn't necessarily panned out. So certainly I'd like to hear other people's input on this, but I think it's an open question right now.
I had a question for you about the choice of therapy for a BRCA patient. Your data with gemcitabine and cisplatin is so outstanding, and FOLFIRINOX is a lot more toxic regimen. Is gemcitabine and cisplatin your go-to regimen for a patient with such a mutation?
Yeah, so I think, thanks Margaret for that. I think it's a very good and very practical question. So I think if we know what the alteration is and person has a BRCA1, BRCA2 or PALB2 mutation, and that information is available at the time of treatment decision making, then I think using either FOLFIRINOX or using cisplatin gemcitabine is a good choice, and one would feel very comfortable with that. The challenge often is that we don't have that information available in practice when we're making the initial treatment selection. And in that context, we'll prefer to give people FOLFIRINOX because cisplatin and gemcitabine isn't a robust choice for sporadic pancreas cancer. But when we do know, yes, I think so. I think it's reasonable, doesn't require a port, it's well tolerated, and it does add an additional flexibility in terms of quality of life for patients.
And one last question from Eric Collison. Do you find HRD mutated cancers to more or less often be KRAS wild type? How do you prioritize treatment in these HRD mutated KRAS wild type patients?
Yeah, so interesting, and thank you, Eric, for that. I don't know that we know that so much. I mean, we've looked at our BRCA cohort and have not really seen a big difference in the typical driver gene alterations, including KRAS, P53, and CDKN2. Admittedly, it isn't a huge cohort, so we may be missing a signal. I think what we do see a difference in terms of KRAS wild type is that there are some hints in the literature that mismatch repair deficiency may be increased in that population, and that may be perhaps the area to think about. So we're certainly looking at this, and I think others are too. And again, glad to hear if there are different perspectives on this, but our sense is not for HRD are we seeing a lot of enrichment in the KRAS wild type subgroup.
Thanks very much. I think we need to move on to the